We have reached the final session of today's program, How to Pass MD series. This time focusing on management of chronic diseases, clinical trials and ethics viva. May I now invite Dr. Akita Higoda to moderate this session.
As the final segment of the SIMCON 2025 Day 1, we have How to Pass MD Part 2 viva. So over the last few years, we had all 4 vivas being simulated on stage. But since by the college, we organize regular MET sessions, medical emergency training sessions. This time we thought to drop the emergency viva segment so that we have more time for feedback and discussion on other 3 viva stations. So namely, chronic disease management, trials, and ethical reasoning in clinical practice. Today we have a very senior set of examiners, Dr. Barna Millavithana, consultant physician from Colombo North Teaching Hospital, Professor Prasad Katulanda, professor in endocrinology and head of Department of Medicine, Faculty of Medicine, University of Colombo, and Professor Shamali Abe Gunawardana, professor in medicine, Faculty of Medicine, University of Peradeniya. And we have 3 registrars who have volunteered to help us with the sessions. Thank you very much for volunteering and agreeing to help with the session. So I kindly invite all 3 resource persons to the stage to start the viva. So the first session will be conducted on chronic disease management by Dr. Barna Millavithana. And the registrar who has volunteered to help with the viva will be Dr. Eena Aryaratna. So in the interest of time, we have given the case scenarios a bit earlier to the registrars so that we save time on the time given for reading of the question or the scenario. So we'll be displaying the scenario for the audience to read it for around 2 minutes, and then the viva will take place for 10 minutes, followed by a feedback.
So good evening. First of all, I think before starting the session, this will be like more interactive, as well as we need a feedback from you. So you know the MD viva has 4 components: acute, the emergencies, chronic diseases, then ethics and ethical reasoning and trials. So I will give the marking scheme to you all. So what we do is we do a live case discussion, and I will ask you all to use this the marking scheme, and then you can gauge the performance of our candidate. So that is the way you have to learn. So you have to concentrate what we are doing here, and you have to gauge. So this is the real marking scheme we give. So there are 5 categories. This is given in your prospectus. So fail, borderline, pass, good pass and excellent. And you can see in this fail segment, so what we are looking at, whether the assessment is wrong and the management plan is inappropriate. And borderline, satisfactory assessment, but plan of management is unsatisfactory. Pass, satisfactory assessment of a patient scenario and the management is satisfactory, as well as the discussion will be not so fluent, because we need to ask a lot of questions to get things from the candidate. Good pass is satisfactory assessment of the scenario, satisfactory plan of management, and fluent and spontaneous. And excellent is satisfactory assessment, satisfactory plan, fluent, plus the candidate shows the knowledge and candidate applies his or her knowledge to the particular case. So your exercise is taking this to your brain. So it is fail, borderline, pass, good pass. Yourselves see what we are doing here and gauge our candidate's performance. So what I do is the first scenario, the chronic diseases. So we'll give 2 minutes to read the scenario. When bell rings, I will start the 10-minute scenario with our candidate. So when we are doing the scenario, you assess according to that. So you can read this one. So we'll give 2 minutes for you.
Good evening. I'm Dr. Barna Milvitana. I'm your examiner today. I think you have gone through this case. So can you just tell me the key elements in this history, in the clinical scenario you identified in this patient, the key elements of the scenario?
So he's a 82 years old patient with chronic obstructive pulmonary disease, and my first problem is he has severe COPD with recurrent exacerbation. He's getting dyspnea with minimal exertion. It corresponds to MMRC grade 4.
Yeah, just give me key elements. List down the key elements, please.
And also, my second problem is functional decline with frailty.
Okay.
He's wheelchair bounded for last 1 year with muscle deconditioning and also breathlessness. So I would like to assess his frailty by clinical frailty.
Yeah, no, just tell me the elements. We'll assess it in the later part.
Then
right?
other problem is psychosocial issues.
Okay.
And his wife is also elderly person. He is only the primary caregiver of him. So my fourth problem is he's multi-comorbid patient. Hypertension, ischemic heart disease, diabetes, and also depression. Currently he is in a low mood that also affect the treatment adherence.
Okay, so you have identified few problems, like the key elements in this history. So what is the striking problem here in this patient, the main problem?
Severe COPD despite of triple inhalers.
So you are thinking about the COPD is the key problem here. Now, can you tell me how are you going to assess the severity of COPD in this patient?
COPD severity assessed by symptoms burden, number of hospitalization, and also the number of exacerbations.
Okay.
In this patient, he's getting breathlessness with minimal exertion, and also he has 2 more recurrent hospital admission with 2 required NIV also. So he falls in gold E, severe COPD.
Okay. So you know this is a severe COPD category. So other than COPD, when you are managing this patient holistically, what are the other areas you are going to assess in this patient?
Yes, in the holistic assessment, actually I have to look other than his medical condition, nutrition status, and psychological and cognitive well-being, and also functional assessment. And also palliative care needs as well.
Okay, now you are thinking about the other assessment. So thinking about the comorbidities currently he is having, are they causing a lot of problems to this patient? Or?
Yes, he's a non-ischemic heart disease patient and on antiplatelet also because of muscle weakness, but currently he is wheelchair bounded, but because of muscle weakness, yes, there is a possibility of fall, so risk of traumatic problems also.
Yeah, so other than COPD, you would like to assess other domains. That's what you said, like medical, functional, psychological, those things. So thinking about you with the holistic assessment, what may be the goals of care in this patient? It's a chronic problem.
Yes,
what are the goals of care you would like to?
According to history, sir, he falls under palliative care other than aggressive medical management. So main goal is symptom relief, as well as improve his function and also improve his quality of life.
Okay, so you have you heard something called ceiling of care?
Yes.
So what is ceiling of care means?
Ceiling
In sort
of
chronic patient?
The ceiling of care is realistic limits of treatment escalation based on patients' preferences and prognosis of the disease, and also patient's health. In this, according to this history, the ceiling of care of this patient is optimum ward-based management rather than escalating ICU care or medical ventilation, mechanical ventilation.
Okay. Now this patient has a lot of symptoms. So pharmacologically, what can you do? You as a medic, what can you do to improve his symptoms? Because you are targeting quality of life.
Yes.
What are the things you can offer to him?
Pharmacological wise, I would continue triple inhaler with good adherence and correct inhaler technique, as well as during exacerbation, I prescribe short course of steroid, and also for the symptoms improvement, low dose of opioids, and also antibiotic prophylaxis to prevent further recurrent exacerbation. And I'll arrange a vaccination and also review comorbidities and optimize that. And also I'll check if patient is a candidate for long-term oxygen, and I will arrange.
Right. Those are the aspects you think about pharmacologically. Any non-pharmacological measures which can help?
So pulmonary he's a candidate for pulmonary rehabilitation. It will reduce his symptoms as well as reduce decline lung function, improve lung function also, and also quality of life. And other thing is nutrition optimizations.
So any measures you can take to prevent? Now he will come in next time with the severe exacerbation and he may go into ICU. Are you going to put him to ICU or anything else when he go home this time, or while ready to go home you can do to this patient?
No, sir. I didn't escalate for ICU care or mechanical ventilation.
So why is that?
Because he has multiple comorbidities.
Yes.
And also he's in end-stage COPD, yes, despite of inhalers.
So you are not going to further escalate.
Yes.
So before he is getting bad, so it is like going into crisis. Anything else you can do in this clinical state with the patient and family?
I will arrange open discussion with the family, and also currently he's in a sound mind. So I will arrange an open discussion with family, with the patient and caregiver, and also family. Mm-hmm. Then I will discuss with them regarding the prognosis of the disease, available treatment option other than invasive interventions. And I will make a plan for anticipatory care also.
Yes, what is anticipatory care or advanced care planning?
Since this patient is deteriorating, we need to make a plan for future care of this patient to keep him comfortable. That reduce the stress of the stress for the patient and the family, and also it avoid emergency decisions during exacerbations, and it included other than palliative care, it included advanced directive care and also legal arrangement and also resuscitation plans.
Now the wife has a problem. She said she can't manage. So as a medical doctor, how can you help this wife as a primary caregiver to look after this elderly person who's getting shortness of breath?
Yes, she's 75 years old, elderly person. And I will arrange a social worker, and I will support him with them economically, financially.
Okay. Have you heard about? Can you do it alone, or do you need a team to do this? What sort of team you need to help this patient and the family wife to the rest of the management?
It's a multidisciplinary team decision.
Okay.
It includes physician, respiratory physician, physiotherapist, nutritionist, as well as palliative care nurse.
Right. So imagine this patient coming with like the cardiac arrest or like peri-arrest situation. What are you going to do to the ETU?
I will not escalate the treatment. Once he get the once he recovered, I didn't escalate this patient's treatment. Yes.
The patient went into respiratory arrest.
I will manage with NIV.
Respiratory arrest, NIV is can you use NIV in the respiratory arrest situation?
No, I will ambush this patient and
Okay.
then.
Right. So the time is over. Now I think I have given the marking scheme. So you all can grade her performance. And meanwhile, you can grade and tell whether you are going to pass her, whether you are going to give borderline or fail, or whether you are going to give good or excellent. Meanwhile, I'll ask from you, how was it? So first feedback is from the candidate. How was it?
This is a complex scenario.
Yes. So how do you assert now? This is the first time you are coming to as exam. So it is the main thing. What you have to is you have to practice and get used to this situation. So your performance wise, what went well? What went well?
Medical management part.
So
It's
medical
okay.
management part, you had a good knowledge,
Yeah.
right? That's what you think.
But palliative care wise.
Yeah. What are the gaps you identified in facing this sort of chronic disease management?
These type of patients, we have to mainly focus on the palliative care.
Yes.
Management.
So the gaps in the knowledge in the palliative care and the other gaps in anticipatory care, those things,
Yes.
right? Okay. So shall I ask from the audience? So can you put your hands and say who are the people who are going to give excellent to her? So that means excellent means everything is perfect, not perfect. It is like good assessment, good management plan. She was fluent and she has good knowledge regarding this case. Who are the people going to give excellent? Good. Right. Okay. Who are the people going to give fast? Yes, few people. Borderline? Nobody. Fair? Right. So what we do in the exam, we have the calibration. So I use the calibration. I actually give a pass mark to her. And the key elements, she identified the key elements. And I have done a little bit of prompting to get things out. And as well as the grading of severity, she has some knowledge. But what I saw is the knowledge is not structured. That is what we see in the PG trainees. You have the knowledge, but you have to put the knowledge in very structured manner. You listen to the question, think the question, give the answer in order. That is the structured way. And the other thing we expect from PG trainees is not just recall the things and tell us. You have to clinically analyze the case, analyze, synthesize, and prioritize. So those three things are very important in long cases as well as the other things in the clinical reasoning things, right? Chronic diseases or long case. So you have to always, clinical reasoning important, not just recalling. So you synthesize, you prioritize, analyze, those things are important. So she has knowledge. So in the application, there were some gaps. So that's why I put her on the pass range, not went into the good range, right? And I'll ask the others, do you have any comments to give to her performance?
I think she passed, but can be better.
Yes. Okay.
Yeah, I also agree with you. She will pass, but can be better to get more spontaneity and come out in a structured way.
Yes, I also think the knowledge is good, but the presentation you can do better.
Right. Okay, thank you. So I think all of us are agreed. So what you have to do is, as a trainees, you practice these things. These scenarios are freely available. So even your word base also, when you are presenting to your consultant, do it in structured manner. So if you practice daily in these things, in the ward setting, that will be easier. So what I've seen throughout, even my trainees, both geriatrics and general medicine, you have the knowledge, you read a lot of things, and you have a lot of resources, but the gap is you have to develop the skills to apply your knowledge relevant to the case. That is the important. And in this case, the patient has multiple morbid, but the main problem is COPD. So she has identified that key problem, and the assessment, thinking the recurrent exacerbations as well as patient is getting more frailer. So goals is, what are we going to do? So improve quality of life, treat reversible causes. That's the most important message you have to tell. So what we are trying sometimes is do everything for the patient, which is not going par with the prognosis of the patient or the patient's wishes. So that's important. Just not our knowledge or what we see in the patient. We have to always prognosticate the patient, and we have to talk to the patient or patient's relative, get their preferences, and we have to arrange the patient's management plan accordingly. Okay. So thank you very much. I think we have come to the end of our thing. And
Thank you very much, sir, and thank you, Ina, for volunteering for the case. Next, the trials, viva, will be conducted by Professor Prasad Katulanda, and the registrar who will be facing the viva would be Mahesha Sitmini, Dr. Mahesha Sitmini from National Hospital, Galle.
Hello, good afternoon. So I'm Professor Katulanda, and have you read the scenario?
Yes, sir. I have it.
So usually she will get little time to, or usually by the time she comes to the examiner, she has read the scenario outside. So what is the main clinical problem, or what are the problems you have identified in this case?
Yes, sir. This is a 55-year-old patient with prolonged history of type 2 diabetes mellitus for 10 years. And the background, she's having very poorly controlled hypertension and poor glycemic control as well. So she's coming with body swelling, and also there is evidence of nephrotic range proteinuria as well. So the main problem would be the patient is having very high risk renal profile with evidence of probable diabetic kidney disease with very high proteinuria, and also her EGFR is 27. So she belongs to when we risk stratify according to KDIGO guidelines, she belongs to the very high risk category of kidney disease, G4 and A3. So which is a very we have to act upon on that. And also the other problems are that she's having very poorly controlled blood pressure. She's on Ramipril, but we can optimize that. And also the other problem is the suboptimal glycemic control. So in that line also we can act. And the other problems that she's currently on metformin with the EGFR of 27. So we have to stop it as well. So ultimately my major problems are that she's having diabetic kidney disease with suboptimal glycemic control and suboptimal blood pressure control with significant cardiac, renal and metabolic risk factors.
Yeah, so if you prioritize your management steps, what are the important aspects in the management of these patients on a stepwise manner?
Yes, sir. For the management of this patient, I will mainly focus on the management of this cardiac, metabolic, and renal complication in view of managing glycemic control and optimization of the blood pressure, and also optimizing the cardiovascular benefit. So that's the main theme of my management. So I will initially start off with the non-pharmacological measures. So I'll educate.
So while we are discussing, we'll come to that. What do you think, if based on evidence, what might be the most beneficial, single most beneficial pharmacological intervention that you can think of in this scenario?
Yes, sir. In this patient with CKD stage 4 with significant proteinuria, I'll be considering SGLT2 receptor SGLT2 inhibitors in this patient. We can consider empagliflozin or dapagliflozin with the current evidence.
So can you name some evidence, if you know, for the use of SGLT2 inhibitors?
Yes, there are major landmark trials with regards to SGLT2 inhibitors, starting from Credence trial, where they have compared the canagliflozin with placebo in mainly a diabetic cohort of patients, where they have shown benefit with the improvement of renal outcomes. And also when it comes to the other two major landmark trials are the DAPA-CKD and the EMPHA kidney outcome trials, where they have included both diabetic and non-diabetic patients in their cohort. So they both have shown significant benefit in relationship to a reduction in declining in GFR, and also they have shown mortality benefit as well. So other new thing that they have discovered was in the mainly the EMPHA kidney outcome trial, they have extended the spectrum of eGFR up to 20. So in this patient also, there is evidence that we can start on SGLT2 inhibitor.
Imagine that this patient is unable to tolerate SGLT2 inhibitors, or else had some major issues in the past with the SGLT2 inhibitors that you are a bit reluctant to use. Any other options that you can think of?
Yeah, the other evidence, mainly we can consider about the second-line agents like non-steroidal mineralocorticoid receptor antagonists, mainly finerenone, with evidence coming from the Fidelio trial, where they have tried, they have looked primarily into the renal outcomes of the finerenone, and where they have shown significant improvement in the renal functions as well as the cardiovascular outcomes. So,
in addition, what are the trials? In addition, you talked about
Fidelio trial, and the other trial is a Figaro trial, where they have taken the cardiovascular outcome for the primary endpoint. However, that trial also showed some modest benefit related to the kidney outcomes as well.
So, what sort of a drug is finerenone?
It's a non-steroidal mineralocorticoid receptor antagonist. They mainly selectively act on the mineralocorticoid receptors, and they mediate they inhibit the fibrosis and reactive oxygen species formation, and they can have beneficial effects mainly on the cardiac as well as renal functions as well.
Before starting finerenone, what sort of parameter that you'd look into in the patient?
We have to look into the potassium level. So we have to advise the patient regarding the...
You know any cutoff that you can
we
use?
We can consider about around 5.
More than 5 or less than 5?
Should be less than 5. 5.5. Okay.
Now, yeah, you can use finerenone, but finerenone will have mostly renal benefits and renal effects. Now, if you take this patient holistically, in case that the patient cannot be given SGLT2 inhibitor, any other class of medicines that you can use?
The newer drugs that are coming into the picture are the GLP-1 agonists. They have tried for the diabetes control and also the obesity management. Currently, there is evidence coming for the renal management as well. The most recent FLOW trial, they are showing that evidence regarding the improvement of renal outcomes and reduction in proteinuria in that trial.
Yeah. In addition to the renal benefit, what are the other benefits that use of GLP-1 would have for this patient?
Yeah, this patient, she's having diabetes which is poorly controlled. So GLP-1 receptor antagonists, they have insulin-mediated action. So they can act both centrally and peripherally. Centrally, they can reduce the satiety.
Yeah, so that's mechanism. So glycemia,
Glycemic control.
any other benefits?
Weight reduction,
Any other?
and
What is the most possible reason for the death of this patient?
atherosclerotic cardiovascular disease,
So would there
cardiac
be
benefits.
cardiac benefit? Yeah. So other than these things, what are the other overwhelmingly important things that you need to consider to improve the overall prognosis of this patient?
Yes, sir. So this patient belongs to the very high risk EGFR of a very high risk category with the classification G4 and A3. So we need we have to liaise with the nephrology team because she can develop.
Any pharmacotherapy that you would like to also add?
In this patient, she's on ramipril. We can look whether we can escalate on the maximum tolerated dose because we can escalate up to 20. In this patient, we can gradually escalate by monitoring the renal functions and potassiums as well.
Any other medicines that we need to think of?
For the glycemic, and also we have to consider about adding on statins because that's a pillar in the management of the CKD because of the increased atherosclerotic cardiovascular disease risk. So we can do her baseline lipid profile, and we have to optimize her LDL target.
Do you need to base the treatment based on the lipid profile, or you can straight away?
We can start straight away because she's.
Any trials on that?
The trials regarding diabetes and diabetic kidney disease regarding statins comes from the SHARP trial, but there are trials for the primary prevention in statins as well, like
So any
trials.
trial you have heard of which will tell us in diabetic patients, irrespective of the baseline LDL, that you might be warranted to use statin?
I'm not sure about the names.
Right. Is there any studies or evidence?
We have to optimize the LDL target.
Why do you want to send this patient to the nephrologist?
Because starting from CKD stage 3B, because they are more prone to develop diabetic kidney disease related complications like anemia, bone mineral disease, so on. So that needs a multidisciplinary management to optimize the complications related to diabetic kidney disease. And also with the EGFR of 27, we need to decide on her long-term plans as well because she might need renal replacement therapy in the future. So we have to discuss with the family and the patient and decide on the long-term management plan as well.
Now, you say that you might have to take off metformin. So what sort of effects it will have on overall the management?
Yes, metformin, we usually omit at EGFR of 30 because there's increased risk of metformin-associated lactic acidosis. So with that, in very low EGFR patient, there's risk of developing severe lactic acidosis. So in this patient, we have to omit metformin. But ideally, that has benefits, but in this patient...
So what sort of things might happen when you omit metformin?
It might interfere with her glycemic management.
So then if it is... Yeah. So I think it's over. Time over, no? Yeah. Right. So how did it go? Generally, I think you did quite well, and you were fairly thorough with evidence, and even you knew by names. Sometimes actually some people have difficulties remembering names of clinical trials and so on. So we won't really penalize them for not knowing all the names, but they should know the evidence. But at least the landmark studies, you need to know at least few landmark studies to quote in the exam, because you are going to be an expert specialist, so you should be able to know these and tell your juniors, trainees subsequently. So we will expect at least landmark studies. Very important. The other thing is, so I don't want to go into detailed on getting your feedback. I think I might give a fairly something between excellent and good. So if you knew about card study in statin, I might have definitely given you excellent. But even without that, I would have definitely given a good pass. What do you all think? Yeah. So generally, if a candidate teaches us more than what we have expected, like in the preparation, then we generally definitely give them excellent. So if the candidate is shown to know more than us, so that is how we mark your. But definitely, you'll be given a good pass. Any other feedback you want to give? Other thing is, what my advice to you all also trainees is, now I think you don't need to by heart the evidence and clinical trials. Try to make it a habit when you all do ward rounds, when you take clinical decisions, to discuss with your consultants as well as your colleagues what is the evidence and so on, and make them familiar, so that after a while you don't need to really by heart, you know them, and also go to the main clinical meetings, the meeting of the internal medicine, CCP, then endo, cardio, and where a lot of evidence will be discussed every year. And if you go to sessions, all these most landmark studies will be discussed. So you don't need to by heart. You get familiar with the evidence, and you apply the evidence. And also when you apply, again be conscious and try to remind yourselves what is the evidence in the words and as well as when in your discussion, so that you don't need to take an effort to remember. So that is something that I would like to give as an advice in the preparation of for the evidence-based component of the viva.
Yeah, just one comment. I think the most of the wards we are doing journal clubs and guideline discussion meetings. What I tell always to my trainees, we'll use a case scenario, and according to the case scenario, we will base the discussion rather than just getting the guideline and reading and doing some cut and paste work that may not give a lot of knowledge. So what you have to realize is how I am going to apply the evidence to that particular case. That's what I always say.
Yeah, I think you're quite familiar with the common trials, and also you answered without any prompting. So I also think that you should get a good pass.
Congratulations, Dr. Nimesha, on that excellent comments. And thank you, sir, for your input and guidance. Next viva on ethical reasoning in clinical practice will be conducted by Professor Shamali Abegunawardana and Dr. Sharini Solangarachi, Medical Registrar from National Hospital Galle, will play the role of the candidate.
Good evening, Shalini, and thank you for volunteering to come to the hot seat. So we'll start with the scenario. The first question is, okay, so what are the ethical principles involved in this scenario at the time of admission?
Yes, madam. The patient is 82 years old who is acutely unwell without previous medical records, coming up with respiratory distress, and immediately patients become drowsy and shouts of imminent respiratory failure, madam. This is an emergency situation, and in these situations, the main principles, all 4 pillars of ethics would apply here, but I think autonomy and also beneficence governs the main part of the ethical principle in this at the admission, madam.
Okay. So next question is, how do you apply the principle of autonomy in this type of scenario or this scenario?
Yes. The patient is 82 years old and age is not a barrier, but patient is in the respiratory distress and drowsy. So autonomy is the patient's right to, and also the respect the patient right of taking the informed voluntary consent regarding her own management, madam. But in this situation, because patient is drowsy, there's a problem with patient is not capacitated. So incapacitated patient. In this case, as a principal, we have to look for whether there is an advanced directive before this, and also if there's a not advanced directives are there, whether any power of attorney is there. If not in that case, also next of kin would give the autonomy in the taking the decisions. But madam, in the emergency situation, in the best interest of patients, we have to manage the patient.
What is the ethical principle behind the ETU physician's decision to intubate?
In the ETU, at the admission, patient is in the respiratory distress and imminent respiratory failure. So it is an emergency situation. So in the best, because, and also the records were not available at that point. So the point is to saving the life, and in the best interest of patient, I think the beneficence is the main ethical principle governing this situation. So best interest of patient, I can justify the emergency physician's intubation decision in this situation, madam.
And the principle is?
Beneficence, madam, in here.
So if the patient said not to intubate at the ETU, what is your decision as the ETU physician?
Yes, of course, as an ethical principle, autonomy, we have to, actually it's the main pillar of the ethical principle. But in the emergency department, provided patient is drowsy as well in this case. So I have to first assess the capacity of this patient while providing the maximum care for the patients with the respiratory support, because patient also in the respiratory distress at this point.
So what you are trying to say is you need to be sure about the
capacity of this patient, madam. Yes.
So how do you assess the capacity?
The capacity is, madam, actually a cognitive ability of a patient to, after regaining adequate information and understanding of the case, and also retaining and give a valid reasoning and processing and the communication. That is the capacity of the patient. So assessment, ideally, we have to get inputs from psychiatry or team or like that. But if not available, even with there are some capacity assessment tools as well. So we can use that for assess the capacity. But as I previously said, it's an emergency setting. We have to take the best interest of the patient. If there is a delaying getting decisions, we have to manage prompt and we have to manage immediately.
Okay, so now we'll go into deep water. Now we'll assume this patient has capacity and say not to intubate. What would you do?
Yes, madam. In that case, as patient is having capacity, this is, madam, before tracing the previous records. Yes, at the emergency. Okay. So, madam, in that case, if patient is having the capacity, I have to respect the patients. And because as a clinician, I know the best interest patient, the intubation, maximum care, if intubation is indicated, I have to do intubation. But, madam, in that case, I will further inform and discuss with the patient. But anyway, the autonomy is the main governing principle. If patient is having the capacity, I have to respect for that.
Okay. So in the current state of illness with prolonged ventilation and ventilation-associated pneumonia and other complications, discuss the ethical principles that would govern further management. And the second part is how you would justify the decision not to escalate.
This patient, the actual history is like he was having advanced chronic obstructive airway disease. And also, patient is after ventilation. Sorry, madam, can I have again the question?
The question is, now at this stage, So what are the ethical principles that come into play, and also how you justify your decision not to escalate
Not to.
based on ethical principles? We have decided not to escalate.
Yes, ma'am.
So how you justify based on ethical principles?
Yes, ma'am. Because after managing the patient, because the treatment, here the main principle is non-maleficence, madam.
Right. Okay.
Because the patient was intubated, and also patient now complicated with ventilator-associated pneumonia as well in the background of chronic disease, and patients who is already on a patient is having chronic illness, and also now
So
patient
you
for
are
the
considering only the non-maleficence, or you consider anything else as
justice,
well?
justice as well, madam.
Justice, and for the patient?
Patient's autonomy and also beneficiaries, madam.
Beneficiaries.
Beneficiaries is also.
Okay. Right. So how do you handle the strong request by the wife?
Yes. This case, madam, again, this is a main concern regarding the autonomy. This wife concerns is coming up, and also as a patient's wife, I have to respect her decisions as well. But anyway, I have to first, this is regarding autonomy, the patient's, if capacity, that is the patient is having the autonomy. And if not, patient is not having the capacity, again, I have to look for advanced directive before this consent. And if there's no advanced directive, even power of attorney, if there's a nominated person, I have to, the decisions taking power is having that person. If there's no power of attorney as well, then next of kin, in this case, possibly wife, he's having that ability to take the decision. So I have to respect, but madam, the thing is, patient is having chronic illness and already ventilated, and patient is now further complicated with pneumonia, and the multidisciplinary team decided not to escalate because mainly non-maleficence is there, and it's not futile, the treatment is futile. In that case, madam, we have to, one thing is wife is possibly not in the receptive state at this point. So I would further discuss with wife, and also if wife is allowing me, I will, family member also, I will further discuss regarding our multidisciplinary team decisions in this case.
So the last question. So during the meeting with the family, the son who lives abroad and returned because of his father's illness requests the possibility of discontinuation of life support to end his father's suffering. So how do you approach this situation?
Madam, it seems that after our MDT meeting also, we decided do not escalate. It seems like son's decisions also parallel with our decision. But in considering the decision-taking power and the legal background, I have to respect son's decisions as well. But anyway, in this case, again, the decision-making ability is here is again with the wife. According to because of the when consider autonomy as my principle. So in that case, even though son is requesting to stop the management, I have to discuss. We have to get parallel with the wife as well in this case.
Okay. So thank you very much. So the first part of the discussion, I think it was, I would say, excellent. Right, so latter part, I think certain areas we will discuss that later. So I think before we discuss the case, so I will talk a little bit about about this segment of the exam, because a lot of trainees and candidates are quite uncomfortable with this segment of the viva. So actually, the first thing I want to say is how to handle the scenario. So what you get at the exam is a very common clinical scenario with an ethical dilemma. So that means, what is ethical dilemma? So that is, there are two or more conflicting ethical principles are acting on a problem, right? So what you have to do is, you have to identify the key problems and apply ethical principles, and then you need to reason out how to address these issues using ethical principle, right? So what is the level of competency, right? So there are two competencies we check. The first one is the initial evaluation, and the plan. What is your plan to address these issues? So if you have satisfactory initial evaluation and you have a satisfactory plan, even with prompting, and even if you're not fluent, still you can get a bare pass. And so you can judge how to get the clear pass and a better pass, right? So failing is also like that. So the next one is, right. So what are the cases you get in this ethics station? So that is, of course, very difficult to predict, right? So it could be anything. That is what you see in the ward. But then I can tell about some common areas we check. The four main areas: autonomy, beneficence, non-maleficence, and justice. You have to know. And in addition, informed, not only the informed consent, everything about consent, implied consent, and who to give consent, who not to give consent, etc. Capacity, accepting error, truth-telling, confidentiality, end-of-life decision, and allocation of scarce resources. So what you have to do is, you need to thorough with these areas and then face the scenario with confidence, then you are okay, right? So, right, if you go back to so I have very little time. So the first part is okay. The decision not to escalate is because there are two principles, that is beneficence and non-maleficence, right? So here the non-maleficence overrides the beneficence. So that is the basis of that decision. And also in that, when the beneficence, there is no beneficence, then you have to consider the justice. You need to remember the first three principles are for the patient, and the justice is for the society, okay? And this how to handle the strong request of the wife. So actually the expected answer would be, you need to handle you have to deal the wife's emotions and concerns with a lot of empathy and compassion. However, she does not have a proper legal right to decide on the husband's the treatment. But it's very important that the family should be aligned with your decision, and as much as possible, you need to get them on board with your decision. So that should be the answer. So you need to take a lot of time and explain to the family that that this decision was taken purely for the benefit of the patient. So I think the time is over. So I think one thing I need to take regarding this switching off the life support, right? So that is switching off the life support in a patient without confirmed brain death is not tested in Sri Lanka, and you may not be covered, right? So you have to handle these things very carefully, and always remember, law is above the ethics, right? Okay, so any comments?
So thank you, Sharini. I would like to take this opportunity to thank all three resource persons who appeared as examiners today, and also the three medical registrars for their bravery. I would also like to invite the three registrars who volunteered on the stage for a group photograph once I present the certificates of appreciation to the resource persons.